Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour, and Spark Live is where we gather each Wednesday to curate and convene and showcase excellence and innovation from across the child and youth healthcare community, with our goal, as always, to spark conversation, ideas, and action. And since we are live, I do want to remind everyone that you do have the opportunity to type questions into the question box at any time. Don't feel you need to wait till the end of the presentation. Go ahead and type those questions in as you think of them, and then we have them ready whenever our presenters feel the need to see if there's any questions. And also feel free to share your thoughts on Twitter, but if you do, be sure to tag us at Child Health Can. All right, today we're going to be talking about quality improvement and getting buy-in at the frontline level. Quality improvement is always a topic of interest for our audience, but one of the challenges that inevitably presents itself is that issue of getting buy-in from various stakeholders, and often at the front line is a challenge. And today we're going to hear about how one hospital has made a special effort of getting that frontline buy-in. Today's speaker, Kim Pike, originally presented this as a short presentation that was part of our What Changed My Practice session at our conference last October. Those sessions were shorter presentations on these topics of interest, and there was such interest in them that we've been taking an opportunity to bring some of them to our webinar program so we can have a bit more fulsome discussion on these topics. So it's my pleasure to welcome Kim Pike. Kim is the Regional Director of Emergency Services and Ambulatory Care with Eastern Health, and Eastern Health is the health region that covers the eastern part of Newfoundland that includes St. John's and includes the Janeway Children's Hospital. And Kim has been there for 20 years, starting as a nurse in the Neonatal Intensive Care and then moving up into the quality improvement positions that she currently holds, or the Director of Emergency Services and Ambulatory Care position that she currently holds. And without any further ado, it's my pleasure to hand the virtual podium over to Kim Pike.
Thank you, Doug. All right, you can hear me okay? Good?
Yep.
Okay. So what I'm going to talk to you about is how, and this was in an initiative that I started in my previous job as the manager of emergency services and ambulatory care at our Janeway Children's Hospital. So it's it's just about getting staff involvement, which has always been a challenge. And so we'll just go through I'll give you some things that we did and how we got there and where we're going. So, I mean, most often the issue is that quality improvement isn't my problem. Staff aren't engaged, some are engaged in quality improvement, but most feel that, it's another department that flies in, tells them, this is not the way to do things and we need to do something better. Or, Accreditation Canada says that we have to do this and nobody really understands why or why they should really have any part to play in it. And then, sometimes they feel that, I've said this has been an issue and, we don't seem to see any change, or, anytime quality improvement comes around, speaking of the quality department, it's they're only looking for someone to blame. So my intention was to make a change in that. So what we first did was our Eastern Health as our regional health authority, developed a Quality in You type education program that was intended to promote awareness of quality improvement and occurrence reporting. The main focus of that education piece was to let frontline staff know what quality improvement was, and focused a lot on some key things that the organization as a whole was looking at, such as like, your hand hygiene practices and some things like that. So, and it was all led by a quality leader, with the hopes of getting frontline staff and management involved. So that was where we started. I started having discussions with our quality department to see, okay, well, let's do that and let's bring it a little bit more frontline. So we did have our quality leader come and hold education sessions with the staff just about what the quality department was in Eastern Health, and what was quality improvement, and what part they had to play with it. And we did some pre and post surveys on quality improvement, just to see where the staff were and what they felt was what was quality to them. And so this is the results of the pre and post tests. So the blue line is the pre-test. As you can see, the scores are higher after some education on general quality things. And the big focus when we had this, we had these meetings with our quality leader in the department. We were discussing about, what did quality mean to you as the nurse, as the registration clerk in the emergency department? What did that actually mean to you, as opposed to what quality is for, the overall organization, which, can sometimes be a little bit different. So it was getting staff to identify some of the key things that they thought was quality, and what was quality care, and how could we provide quality care, and things of that nature. And so when we went through that, there was a lot of discussion, and the things that I've mentioned before about staff not being necessarily involved with quality improvement, it came evident in those the pre-test questions, and the discussion that was happening before we had further education was that staff really didn't think that, they could bring up something, but it wasn't really necessarily going to be addressed, or someone else was going to do it, and someone else was going to tell them how they needed to be providing quality care. So, and like I said, when they focused on the Quality in You type processes in other units within Eastern Health, it was there was a gap between what staff maybe felt, not that they didn't feel that things needed to be worked on, and the things that were being identified weren't quality improvement indicators, but didn't really fully understand, or didn't really think that, well, they could come up with things on their own, which was kind of the focus that I was taking, and just a different approach in trying to get frontline staff to be the quality leaders, as opposed to having a quality leader come in. And of course, the focus then was to move on to, okay, well, how do we operationalize and continue on with our education of quality within the department? So we started having quality huddles. I had a quality board in the emergency department, and this was very much, I gotta say, a resistance type thing, because the board is in the main, it's the back hall of the emergency department, which is right next to our trauma room. So not a private area, not a completely public area, but certainly a place where parents are wandering around and, could be standing for a period of time. So the potential is there that they would be reading that board. And I did that purposely because I wanted staff to be able to see the board, because every staff member that comes into the department, it's between the bathroom and the main area of the emergency department, and the locker room in the main area. So I was using it as a communication tool, not just between staff and whoever was going to be at our quality huddles, but also with the public. We had, parents coming, that would be going around the department. And I felt that we needed to start making a change in educating families about, and the public, that, we're looking at what we're doing here, and we're working on, areas that we see there are gaps, or, there's fall downs. Then we have space, we have areas of improvement, and we're working on those. And so, there'd be nothing up there that wasn't patient sensitive or anything. Even if we did review certain, maybe a specific case, it was generic information that would be up on that board. So it required a fair bit of discussion with staff. And that was, that included the leadership team within the emergency department, and, kind of bringing it up at staff meetings several times to say, what do you think? What do you see are the barriers? What are you concerned about? And then seeing how we could go, move that forward, and having public awareness of, we're doing quality improvement. And I said, if you ever sit across from a family who has gone through something that we could have done better, then they're always saying, I just want to make sure that, our discussion today is going to mean that this isn't going to happen to somebody else. And they just want to know, most of the time people just want to know that, we recognize we made a mistake, and, or there was a gap in our process or our service, and we're working on it to make it better. And I thought that, this board was a good way to show that. And I wanted staff to be able to see the board, have conversations amongst themselves. Wouldn't necessarily be something that I would be constantly, okay, well, we're going to talk about quality now, type of thing, but have conversations happening within the department on an ongoing basis. And then, so we started our weekly quality huddles after those discussions, and the intent was the huddles would be 15 minutes. Everybody would stand around the board, and then we'd identify what our issues were and what our concerns were. We did focus, even though I didn't want it to be all about occurrence reports. We did start initially focusing on those, because just to get conversation started, because as you can imagine, you bring a group of staff around, nobody really wants to talk. And the expectation is that, me as the manager at the time was going to do all the talking and the telling and the saying, and then they were just going to take it away and do. But that wasn't the long-term vision of where these quality huddles were going to go. So this is a picture of the board. And it's just to let you know, it's kind of a moving target, I'll say, I guess. We have some constant things on the left, which are our program occurrence reporting and our emergency specific to the unit reporting. Then we have things that, anybody can write up a topic that they want to talk about. And then, then we had an area of, okay, well, how are we going to improve patient outcomes, and seeing what concerns are brought up. And then this was kind of, we put up a topic or an issue that we saw. And then as we talked about it, I'd write on the board, this is going on, what's the next step, when we're going to get feedback, if there was deadlines and things like that. We'd also use it as a communication tool if there was something changing with certain medications and things like that. And then we had a clinical corner on the far right, which highlights more practical hands-on things. So if we had a new syringe pump or something, then we put down maybe a couple of tips, or where you could find further information about using that. But the intent, like I said, it's a 15-minute huddle, 15 to 30 minutes, and everybody usually stands around and and we're having a conversation. There's no script, there's no agenda per se. And this is just a sample of staff standing around, but there's no one's expected to follow a script or anything like that. And we kind of move through the board and have the conversation and talk about, okay, well, what's a burning issue? And I have to say, slowly but surely, staff started to have conversations, and we started to, it was more about all of us having the conversation, as opposed to just me talking or the clinical educator having the floor, I'll say, to say, well, you know what, I see that this is an issue, we have to work on it. We slowly started to get staff identifying gaps, and also then working on solutions. So when the problem would get put on the board and we saw it as an area that we needed to work on, then staff, the expectation was that staff would volunteer if that was a topic of interest to you, then you could sign up to start doing some work on that. And that could be doing lit reviews, that could be reaching out to, other pediatric hospitals across the country, reaching to our counterparts in the province, things like that. And just to see, okay, well, what are they doing elsewhere with this? Or, kind of, like I say, group problem solving within the department. So we started to be identifying issues and resolving them, which I think was like the huge thing when staff started to realize, oh my God, if we start talking and we're coming up with solutions, we're actually implementing them. Like we're, leadership is there and, they're interested. She's interested, she's listening, and they saw that things were slowly getting done. So then they started to realize, you know what, I do play a part in quality improvement. I do play a part in how things work here. And it's not all about trying to figure out, okay, well, who made the mistake and how are you going to stop that mistake from happening again, which, is not very good at all. So to go through, just list some of the things that we accomplished in the quality huddles. And this is over probably, I would say about a year and a half or so time frame. And like I said, it was very slow to get started and it was mostly me talking. And, but like I say, we turned a corner and staff started, bringing up issues and moving them forward. So we did triage first, which the process was developed by the frontline staff. I said, the goal is to do triage before registration. And I said, how we do that, you guys figure it out. And, we managed to do that. And it's working quite well. We've done various medical directives. We've streamlined our documentation. We've improved our signage within the emergency department. We've got, like I say, we've had staff volunteer to take on projects. We've got standardized order sets now, and we're also addressing occupational health issues. So we had, one of the things that I think really sticks out to me is that one of the rooms had a medication cupboard bolted on the wall. There was nothing else around it other than this medication cupboard was stuck on kind of like in the middle of the wall. But yet we always had a chair under the medication cupboard. So you had to be constantly reminding parents if they were sitting in the chair, now be careful of your head when you stand up. Or if somebody came in, if you were backing up, we had a couple of staff that backed into the cupboard and, of course, the sharp corner. So when it came to me and they said, well, I don't know why we got that cupboard there. I said, well, why do we have the cupboard? And they said, well, it's always been there. And so it has, I think it has to stay. And I said, well, if we can find another spot, I don't see why we have to keep it there. So they took charge of figuring out where they could find another spot to put the cupboard that was safer. And within 2 weeks, we had the cupboard moved. And then they were like, oh, we can actually do things here. So, not that, but people sometimes get caught up in no one's going to listen and things like that. So, but it's been positive. So I'll just go through a couple of, in a bit more detail, I guess, how things are moving, because I don't think that really, the list that I put here is any kind of, super thing that you could take away and say, you know what, if we do that, then this is going to make a difference to my organization. But I think it's more about the process of how we got where we are that has really made a difference. So early on in our quality huddles, we had an occurrence report submitted outlining the issue. We had a child come in who the nurse had the feeling that, you know what, I just don't have a good feeling about him. I think there's something going on. I think he might be septic. Nothing really concrete. The physician who was on at the time was like, no, I don't think that's the case. And anyway, there was a delay. The child was septic, and there was, when the case was reviewed, there were gaps in communication. We didn't really have standardized processes, and some people question whether we ordered the right tests at the right time and things like that. So it was discovered that the staff didn't feel that they were heard when they voiced their concern to the physician. in fairness, there was nothing really concrete or black and white. And, some people are more about black and white than others. So then, we had several discussions actually at the Huddles to, ask staff what they thought should happen to prevent this from happening again. What do you feel you need as a frontline nurse to be able to deal with that type of situation when you're struggling to get your point across, or you don't feel like you're being heard, things like that. And then, to ensure that we're providing the best care that we can to children. So we developed a sepsis trigger tool, which identifies potential septic patients at the point of triage. So the form that gets initiated at triage based on vital signs. We developed a standardized order sets. We did education with nursing and physicians, and we evaluated the trigger tool to ensure its accuracy. And we made adjustments, I'll say several adjustments before we got to our final product. And that was all based on evaluation. And like I said, it's not rocket science what we developed, because really what we did was we reached out to, the rest of Canada to see, what sepsis tools are you using? Do you have an order set? Do you have, standing guidelines and things like that? And so, we didn't reinvent the wheel, that's for sure. But what we did was that we showed staff that the positive change that can come from an occurrence report, and if they bring up a concern and they bring up an issue, we'll listen and we'll see what it is that we can do to make things better. And they worked through the process of researching what sepsis tools were out there, spoke to physicians about why this drug over that drug, why are the vitals listed as this, why is the respiratory rate this, why should the blood pressure be in this range, things like that. So there was a lot of chatter going on within the department, as well as to counterparts across the country. And then they could see, okay, well, if we implement this tool, what impact is that going to have on the department? And how is that going to impact my work every day in the Emerge? Identifying problems, develop solutions, deciding what could work, what wouldn't work. And, it wasn't me coming as the manager to say, we had an issue with a child who was septic. We had a delay in care. We're now everybody has to fill out this tool. Here you go. There was much more buy-in, because staff were then, if somebody was, maybe complaining because, well, we got to fill out this tool. Well, I don't know why. Most everybody in the department knew why early on, and certainly everybody knows why now. And, and it helps the nurses feel that, I can concretely, objectively tell you why I have this. I don't have a good feeling about him, which, we often tend to do when we're caring for kids. So the next thing that we did was, we standardized some of our documentation. So our observation room record was at least 15 years old. It was mostly narrative. So, I wrote down what I felt I should document. Everybody goes through an orientation and what they're supposed to be documenting and where they're supposed to be documenting and things like that. But trying to remember all those things, especially when, while we are the Pediatric Tertiary Care Center for the province, we don't necessarily see everything every day. And certainly, thankfully, certain critical situations conditions we don't see on regularly. And so, which is a good thing, but at the same time, you're still expected to be documenting what you need to document. So you can easily forget to, probably miss something especially if it's something that you don't do every day. So we identified gaps in our documentation. We had a fair number of newer staff that were working, and this area is where pretty much all the new staff coming to the emergency department are working. So they're the ones that are certainly have less exposure to various pediatric conditions and things like that. So, they're expected to know a lot, to remember a lot. And but now when we sorry, when we had nurses then say, why there was gaps in documentation, they often said, well, I didn't have time. I knew I had to do that and I did it, but I didn't have time to document it. So we developed a tool that was designed to be easy and quick and, easy to complete. It's tick boxes with reminder cues for what should be included, for those conditions that you don't necessarily see on a regular basis. It's easier and quicker to read. There's areas, it flows like our physical assessment flows from one system to the next in an appropriate order. And, it was all developed by the staff. So again, I go back to, it was all staff input that were able to say where they wanted things, how, if I was going into the bedside and I was doing an assessment on a child, this is where I would start. So this needs to be at the top, this needs to be second, this can be on the bottom, what needs certain spaces and things. I will say that our person in the print shop got a bit frustrated a few times and had to keep reminding us that it's still only an 8.5 by 11 piece of paper. So, so we had to keep within those constraints. So those are just a couple of, standardized things. Something else that kept coming up, which I think, we're seeing where Newfoundland certainly is no different than anywhere else, but we're seeing a lot of mental health issues coming up. We're seeing increasing numbers of children with suicidal thoughts and plans for suicide, certainly anxiety and things like that, and inability to cope. And in the emergency department, a lot of the nurses, this is not an area of expertise for them and certainly not an area of comfort. Because it's not something concrete that I can fix. It's not a cut. It's not a broken leg. It's something that needs a lot more, communication and things like that and conversations. So staff were really struggling with how to care for the kids that come in with, the thoughts of suicide and going through hard times and things like that. And our hospital policy states, which is an organizational policy, I should say, it's not just for the Janeway, it's for Eastern Health, says that all patients with suicidal ideation are to be placed under constant observation, which is not something you can do quickly or easily. And then oftentimes someone from our mental health unit would come and say, well, no, they don't need to be observed constantly. They're fine. You just need, yes, they have thoughts, but you don't need to, they're okay. And then it was kind of, well, how do we figure out if they're okay? And, we should be able to do better care for our patients if we're, able to do a better assessment. We can do a physical assessment. Why can't we do a little bit of a mental health assessment? So our clinical educator found this tool, and it's from a school department, actually, school district in Dallas. Most of the other assessment tools out there for mental health are kind of geared towards someone who has an extensive mental health education. So not really something that the emergency department can take on. And we certainly wouldn't be able to have all of our nurses be experts in mental health. So we found this tool and we met with them. We sat down and reviewed it with our mental health counterparts to see, is this reasonable? Is this, something that you think would be okay? And we're not going to be putting people unnecessarily at risk. So the discussions with them, which also involved frontline staff in the emergency department, was, okay, well, just try it. We don't need to change the care that we're providing. If you still, you were going to think that put this child under constant observation, well then, continue to do that, but just try using the tool and see then what feedback comes back from the mental health nurse to say, you're appropriate in your assessment, or, it was okay. Johnny is safe to be, sat in the observation room around other patients on his own. So after a couple of months of kind of, trialing this assessment tool, then we found that, this is giving staff some comfort. They're able to do a better assessment than what they thought they could do. And they're able to say, okay, well, now I know why, other than, I think he's okay. Now this, just like the sepsis tool, this gives them a little bit more of a concrete plan as to why I made that decision. because, the concern is that, something will happen and someone will come back and question and things like that. And it also helps then when the mental health nurse is going to come and see the patient, see the child, then we also are able to give them a bit more information than what we were before, which was just what Johnny said when he came in to triage. And so they're better able to figure out, okay, well, who do I need to see first? When we just have, because we unfortunately just have one mental health nurse available to the emergency department. So we're trying to better use that limited resource. So those are just some examples of what it is that we've been doing and what's come out of our quality huddles. And I can't stress enough the frontline involvement and the impact that it's had on staff engagement, staff education, and awareness of, even awareness of what somebody else's job is. And that, we're all part of the healthcare team. We're all here to provide the best care possible. And then how, we each play a role in how that happens. And that, if you bring up something, you see an issue with care or gaps in process or even, equipment and things like that, you bring it up, we work through the whole process and, we all have an equal vested interest, then, things can move along and things can get resolved. Like I said, we've improved communication between, in amongst the nursing staff and clerical staff, but also with our families. Staff are, families will often question, well, why are you asking that? Or what's that for? Now, staff are saying, well, we've got this and this is our process and this is why. And it's all about, providing the best care that we can. So some of the staff have kind of grown that now and are working with other departments to figure out, okay, well, now how can we make bigger changes? So what they're working on is, something that impacts, say, from the emergency department to the medicine unit, and then how can we better work together to make a better flow, seamless flow of patients or if, we're having communication gaps and things like that. And like I said, the big thing is the staff engagement. So some next steps are that, well, these have been, we've implemented the quality huddles throughout the Janeway. So there's quality boards at various units. They're all a little different. And there's no set formula, I don't think. I think it's all about starting a conversation, putting the information out there so that, while, if you're at the huddle, then you're involved in communication, but also then that communication can continue on after that 15 minutes is up. And into the nighttime when, staff are like, well, a lot of, if you work nights, then sometimes you don't always know what's going on or you feel like you're disconnected. At least this way, then the board is there with what you talked about, kind of, points are made. And then you're like, oh, okay, well, now I know what's going on. Or you can jot something on the board to say, what about this? So, and the huddles are now more frontline staff led. As I said in the beginning, I've changed jobs, so I'm not leading huddles anymore, but the care facilitator and the educator are continuing on with those, until the manager gets kind of familiar with the whole process and things like that. So that's really exciting to see because then there's real ownership at the frontline level, I think. And with me moving on to another program, I've we're working on implementing this type of quality huddle approach in other programs. So we're having quality huddles now in some of the other emergency departments and things like that. So which it's all about getting the staff to identify the issue and then work together on coming up with a solution and a way forward. And then, like I said, communicating with your staff is key to improvement. Just 15 minutes and you can make great positive change. And that's it. If there's any questions, Doug?
All right. Thank you. Great presentation. I mean, one of the interesting things about, the takeaways, I think, is, some of the things you're talking about around streamlining documentation and order sets and that sort of thing. We often hear larger hospitals, with large electronic health records, et cetera, these massive implementations across the organization that are designed to make those similar improvements. But this is much more of a grassroots, tangible approach that even smaller hospitals, and much smaller than the Janeway, which is an academic pediatric center, but I'm talking community hospitals, et cetera. So I think there's lots of real opportunity here for people to learn from this in those smaller centers that don't have the capacity to make those large investments in infrastructure and still get the similar outcomes and improvements. So I think it was really a great presentation, and exactly as it said, directed, focused right at the front line. So thank you very much for that.
Thanks.
We do have a number of questions. So again, I'll remind the audience, do feel free to type your questions in at any time while we're going through these questions. A lot of these questions are very specific to the different initiatives that you had outlined. So we'll start with the first one. Came in when you were talking about early on. You were talking about how you switched up your registration and triage process. So they're asking. Just to clarify that you used to have the patient register prior to triage, and then they just wanted to know why you decided to change that process. In Alberta, where the question is coming from, they're adopting a new electronic health record system, and they're looking at ways to have a patient pre-register somehow, and then see the triage nurse. Since they need to have an encounter number, they call it, before they can initiate any nursing protocols. So they're just wondering about why you made that change to try and triage before you register, and sort of give a little more detail around how that process works.
Sure. So, well, it kind of came up as a better way of providing care, because we had, I guess, lineups to registration. And then we just, at that point, only had one triage nurse. And then there was concern from nursing that, somebody could be sick in the lineup. And if the registration clerk doesn't know, who is a non-clinical person, however, you all know that, if someone works somewhere for a while, they get knowledge that they probably was never intended for them to have that knowledge, but they just know some clinical things just by virtue of being exposed over years of time. But we got some new registration clerks and things like that. So that kind of then put a bit of nervousness, I guess, into nursing. And then, the intent, the goal is to have your quick look with the nurse first, which is less than a minute, and then he or she decides then whether you can register or you need to come inside, or decreasing that risk. I will say that our registration process probably takes about 1.5 to 3 minutes to complete, and if we had a lineup, well, then there was concern there. So that's where that came from. And because it was kind of like a sit-down registration process. When you're looking at, because I know, we're actually having those conversations at some of the sites, although we don't have electronic documentation in any of the emergency departments here, but there is conversations being had about pre-registering patients at some kind of a kiosk. But we haven't gone that way. But we wanted to put the nurse in front of the patient sooner rather than later, which was where we came up with that focus.
All right. Thank you very much for that. The next question is asking about, so when you were going through the different initiatives, so the development of the sepsis screening tool and the mental health, the suicide screener as well, and the Huddles, et cetera, just everything that you talked about. The question was about whether nurses were paid for the time they spent working on these projects. So obviously the Huddles were part of the workday, but for some of these other initiatives, was it the nurses that were directly involved in producing these products? And was that just part of the workday, or were there other staff that were involved in the production of these tools and resources?
Well, the sepsis one involved a couple of physicians, so a couple of the emerge docs who had a keen interest in it, and then we had a couple of nurses and our clinical educator. And sometimes the work they were doing was done kind of in downtime in the emergency department. But I think I'm trying to think now because that was so long ago. But I think a couple of them might have got a couple of hours pay to work on that tool. And sometimes that was more involved with doing some of the education with some of the other staff. So we'd set up little mini education sessions, just, informing the people that we weren't getting on a regular basis and that sort of thing, just to make sure that we got everybody. The suicide assessment was done with the clinical educator and a couple of frontline nurses and a couple of nurses from our mental health program. And that was all done while they worked but not paid. Yeah, so if they worked on it after, on their own time kind of thing.
Okay, all right. There were a number of questions asking if they were interested in that suicide risk assessment checklist. Are you able to share that? Is that something that would be on a website at Eastern Health or at the Janeway?
Absolutely. I can email that to you, Doug, after if you like.
Okay, that would be great, and we can put that up on the Knowledge Exchange Network, where the recording of this session will be. We can put any other documents or resources that you can send us. We can put those up there as well.
Yeah, absolutely.
All right, thank you very much. The next question is asking: Have you been able to have the staff generate any metrics that they want to monitor via the quality board? Have the staff come up with sort of metrics that they could sort of measure ongoing to track improvements?
Well, we audit each of the forms that we've used to see if if people are using them. So like the sepsis tool, for instance, is that being initiated on the right patient at the right time? So we've done those. And then if there's any gaps in any of the documentation in using that tool. The suicide assessment, we haven't. But then, if there are any separate ones and just overall, I guess, quality metrics, not really. Our quality department monitors our occurrence reporting, which has gone, it did go up initially. Now I would say that it's kind of stayed the same, but I think what people are reporting is more accurate as opposed, and that's probably not, maybe that's not the right word, but more relevant, I think, and more about practice-based process improvement type things as opposed to possibly what was happening before, in a more of a blame culture. So, our quality department monitors those things, but we haven't, not overall metrics for quality, other than specific ones to specific tools or initiatives, such as like hand hygiene or our sepsis tool.
All right. The next question is just saying that the person asking the question is new to their work on a provincial level, and she's tasked with supporting quality improvement for staff across the province. So she's wondering if you have any thoughts or any suggestions on to effectively lead quality improvement at a provincial level rather than a local level. So anything that you've learned, it's one thing to be able to have conversations in the hallway, which is great when you're all face to face like that. But have you had any opportunity to extend any of this or participate at the provincial level in any kind of quality improvement where maybe some of these lessons learned here have translated to a provincial level?
I haven't, but I just, I guess with the change in my job, now I have a regional responsibility, whereas I had just a site responsibility before. And I think it still involves, any level, I think, still involves having those conversations, but it's getting the right people, I guess, at the table and then having them feed, be able to say what are the issues, what are the concerns, what are things that you feel we can work on, and having and then moving forward from that. So, yeah, while this is very, frontline and grassroots, I think it can be still applicable higher level. But then you just have your people who, your provincial reps would then be getting information from their appropriate health authorities or organizations and things, right? And I guess too, the other piece of it is having a lens as to, well, what does quality mean for the province, right? And what areas of quality are you looking at? Or, are you looking at documentation? Are you looking at standardizing certain care? Are you looking at access? And then, go from there as to identifying, how things can move. I don't know if that helps. But.
Yeah. Well, it's always, I think I'm certain it helps. Always a challenge as you go to those bigger and bigger levels. And it's great that, you've got that great perspective of going from a site responsibility to regional, and then, obviously translating to the provincials, other challenges, but certainly some similarities as well, for sure.
And I think too, it's always important to be able to tie it back to, so that the person that you're talking to, so the provincial view would be on, well, I'll say electronic documentation and having quality documentation across the province. Okay. So then it's, getting those people that are around the table to say, what is quality documentation and what does that mean? And then figuring out, okay, and understanding the why that we need to have quality documentation and why this is part of, certain things are things that we need to be concerned about, so that then those people can bring it back and explain, because you're never going to have one-on-one conversations with everybody, no matter the smallest unit to, the biggest province, right? But it's making sure people understand the why, whoever you have at the table.
All right. The next question is asking about what process did you use to obtain staff input on your various processes? So what communications channels did you use? Obviously, the hallway conversations were a big part of that for the Huddles, but even the quality sort of processes in general, as well as the various initiatives, were there other communication channels that you used to solicit feedback from the staff?
Yeah, we'd have an email. We'd send out emails about email updates, so we'd update everybody on things. But then I'd also send out feedback emails. So if you wanted to, provide input, or this is what we're working on, we'd appreciate your feedback. Sometimes we did surveys, like paper surveys. Doug, you alluded to that. We are paper-based, and so kind of old school that way. And then we'd also some of the ones that we felt were probably going to get some challenges, or people didn't really understand where we were going, even though we had a significant group of people that could see the benefit and were able to speak to it. We had big department meetings so that people could have, we kind of had the bigger group, and then we'd have, get feedback that way. And then we also have a communication book that people could write in thoughts or ideas. Some of the things we had several staff cut up the actual some of the documentation tools and tape them together and leave them for the people who were involved with taking charge of, say, the observation room record, for example. So.
All right.
Yeah.
And this is the last question. So if there are, I'll just remind the audience, if there are any last questions that you're frantically trying to type in to the question box before we finish, this is the last question here that I'm about to pose to Kim. So if there are any last questions, get them in as quick as you can, and we'll try to include them. Otherwise, once we're done this, we'll just maybe get some. We did have a couple more questions come in, so we'll get to those right shortly. So the next question is around just asking or saying that or I guess they're asking, are the quality huddles typically interdisciplinary? And do you find that some groups are more engaged than others? And maybe I'll be less politically correct than this individual, and perhaps physicians were the least engaged in some of the conversations, or were other groups, or were they all equally as engaged?
We had well, mostly we basically have three kinds of staff in our emergency department. We have physicians, nursing, and clerical. So the rest of like allied health professionals, they kind of just come in when we need them. So not that the huddles weren't open to them, but they weren't a regular part of our team. So they didn't come on the Wednesday mornings typically. We had some physician buy-in and interest in participating in the huddles. We'd occasionally get one of them would write something on the board. We had a couple who would, they had a section on the board and they would put up memos from some of the tools and things that had come out from Trek and from, well, now Children's Healthcare Canada, but some of those tools they'd post on the board just as general information and things. So which I thought was really positive. Most of the time, the physician group would get involved in a particular thing, such as like the sepsis tool. So we'd put a call out to say, we'd like a physician or two to be involved. And then, a couple of people would volunteer. So it kind of just depended on their interest. A lot of the stuff that we talked about in the huddles too was, I guess, I won't say it wasn't directly would impact physicians, but was mostly felt by the nursing and clerical staff. So, and like our triage first process, we set up a little, a more concrete working group that would meet on a regular basis to kind of iron out the kinks of that. And we did have a physician sit on that as a standing member. So.
All right. And the last question that we have, again, if there are any other questions, do type them in. But the last question that we have for now is asking about when there's disagreements. So, have you had disagreements between the frontline staff and the leaders or management, et cetera? How do you handle them? And they have a second question that's sort of also more about balancing engagement with staff. So, taking the time to have these conversations versus still getting things done, like your day-to-day business. So just any comment about that as well. But we'll go with the first one about how you handle disagreements.
Well, we certainly had disagreements, and I would say there's probably, if I painted all and you wouldn't know, but we were all, happy and no one had an issue. But I'm sure if you went over there today, you could find someone who had an issue with the sepsis tool or had an issue didn't think that the format of the observation room record was appropriate and things like that. But mostly what we did was, you could have a concern and we could have disagreements, but we all had to keep in mind what the end goal is and then what we have to work with. So we can only work within our restraints or, the confines of our organization or a physical space or, like I say, the 8.5 by 11 size paper, right? I mean, you can't have all this space for documentation if the paper that we can't have 11 by 14 paper when the rest of the organization is using 8.5 by 11. So some of those things we just kind of had to put parameters around. And then, there was an opportunity for people to voice what their concerns were and then why they had those concerns, and then see, okay, well, is that something that's reasonable, or is this just more of a resistance to change concern? And then also, explaining that some things are, we have professional bodies that are requiring us to do X, Y, Z. So then, we have those standards and stuff as well to keep with. So I guess it was kind of, and then, sometimes we just came to we'll agree to disagree. And the majority has ruled that this is the best, this is the best way to proceed forward. The sepsis tool was pretty much, an evidence-based type of approach. So that's a little bit different, right? So then you just, we'd educate people as to why we had these drugs and these doses and things like that. So that was a little bit different.
All right. And the last part of that question was about, how you balanced engagement with the staff with getting things done, either whether it's moving the initiatives from conversation to actually implementation, or just balancing the engagement with getting the day-to-day work of the emergency department done.
Well, I think there were certainly times that we all felt stalled, I think, and I would be one of them, that stuff wasn't moving, or, we'd be held up because we had to present it to, say, our pharmacy and therapeutics committee has to review any form that has medication on it. They only meet every so often. So then there'd be frustration with that, and then realizing that, we almost got this ready. How come we can't use it? We've got kids coming. We should be able to use this. And so, we kind of balance those things a little bit in that, we can have it here just as like a little reference sheet. You can't use it as part of the chart, but you could use it as a little guide for a tool, or, in guiding a conversation maybe with a physician. Sometimes that they were used for that. And then other times we just, we've kind of, refocused on, okay, well, look how far we've come and what we've done. Sometimes when you felt like, nothing was moving or things like that. So we take, sometimes we'd have a huddle that was just about, look what we've accomplished so far and where we are. And then, if things were stalled, then it's explaining and having a conversation as to why things are stalled. And, we're part of a bigger organization that has, bigger processes and things like that. So then, we are not just our own little island that we can just make our own decisions within ourselves, right? So those are kind of the things, I think, how we manage that, which was...
All right. And with that is the end of the questions. So great conversation, great discussion. I think it was, it's really an example of, like we said a couple of times, it's really grassroots, practical solutions to quality improvement problems that everyone across the country experiences. So really, again, a great presentation. Is there anything you'd like to leave the audience with, any sort of key messages or lessons learned, or anything that just as before we sign off, is there any last closing messages you'd like to leave the audience with?
I think the big thing is listen to the staff, set the goal, and and don't be afraid to let them try some things out. I think that was really a really good thing for us in getting staff engaged. Was, they had some parameters in what they could do, and just kind of try it and see what happens, and then see what you can do, because they're a powerful force, and your staff are everything. So I think that's it.
All right, and that's a great way to close it off. And so thanks again to you and the rest of your team out there at the Janeway and Eastern Health out in Newfoundland on the east coast of Canada. Of course, as most people know, we do have a few people in the audience that are not from Canada, so just want to make sure they know where you are. So thanks again for a great presentation.
Okay, thank you.
All right. We do our webinars every Wednesday at 11, as most people know, and it's great when you do get to watch live, as the questions and comments are fantastic and really add to the discussion. But when you can't watch live, we do record these sessions and make them available after the fact on the Knowledge Exchange Network at ken.children'shealthcarecanada.ca. Next week, on April 17th, we'll be talking about the first North American hip surveillance program for children with cerebral palsy. It'll be a look back over the last 5 years since this program was implemented. And for this webinar, we're going to welcome Stacey Miller and Dr. Kishore Malpuri from BC Children's Hospital, going from the far east coast of Canada to the far west coast, Vancouver, British Columbia, to describe the development and implementation of a provincial hip surveillance program that was, in fact, the first of its kind in Canada or the United States. And the purpose of this program is to ensure all BC children receive equitable, evidence-based care to prevent hip dislocations, and a key issue with children and young children with cerebral palsy. So a great presentation next week. So thanks again, everyone, for joining us today. Thanks again to Kim for the great presentation, and hopefully we'll see many of you back here next week. Bye, everyone.